السلام عليكم ورحمة الله.
عليكم السلام.
Okay, I'm Abdulaziz Al-Shammari. I'm R7 cardiac surgery resident from KFMC. So today our speakers, Dr. Mohammed Al-Mutlaq, he will present the HOCM, and Dr. Ahmed Al-Amri, he will present the arrhythmia surgery. And the guest consultant, Dr. Mohammed Al-Shaydan, is the director of King Salman Heart Center in KFMC. So we'll start with the HOCM with Dr. Mohammed Al-Mutlaq. Start, please. You can go ahead, Dr. Mohammed.
السلام عليكم. صوت واضح؟
Yes.
My name is Dr. Mohammed Al-Mutlaq, President Junior, King Khalid University Hospital. Today, inshallah, I will present hypertrophic cardiomyopathy. So, first of all, hypertrophic cardiomyopathy is a disease in which the heart muscle becomes thickening and hypertrophied. The thickened heart muscle can make it harder for the heart to pump blood. So hypertrophic cardiomyopathy is the most common genetic cardiovascular disease. This disorder is caused by mutation in the gene encoding cardiac sarcomere protein, resulting in a variety of phenotypical expression and clinical course. Hypertrophic cardiomyopathy is the most common cause of sudden cardiac death in young people. So hypertrophic cardiomyopathy can be separated into obstructive and non-obstructive type. Obstructive is due to mid-systolic obstruction of flow through the left ventricle outflow tract as a result of induced systolic interior mitral valve movement toward the septum. So hypertrophic cardiomyopathy is usually caused by inherited genetic variant, familial hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy often goes undiagnosed because many people with the disease have a few, if any, symptoms. However, in a small number of the people with hypertrophic cardiomyopathy, the thickened heart muscle can be cause shortness of breath, chest pain, or change in the heart electrical system, resulting in the life-threatening irregular heart rhythm, arrhythmia, or sudden death. Epidemiology. Hypertrophic cardiomyopathy is reported in 0.5% of outpatient population, referred to echocardiography. The overall prevalence of hypertrophic cardiomyopathy is low and has been estimated to occur in 0.05 to 0.2 of the population. Morphological evidence of the disease is found by echocardiography in approximately 25% of the first degree relative to the patient with hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is slightly more common in male than female, and the peak incidence in the third decade of the life, with the vast majority of the cases occurring in the age range between third and sixth decade of the life. Hypertrophic cardiomyopathy usually present at the younger age in female. Female tend to be more symptomatic and are more likely to be disabled by their symptoms than male. Since the initial description of hypertrophic cardiomyopathy, the feature that has attracted the greatest attention in the dynamic pressure gradient across the LV outflow tract. The pressure gradient appears to be related to the further narrowing of the already small outflow tract, already narrowed by the marked asymmetrical septal hypertrophy, and possibly by the abnormal location of the mitral valve, by the systolic anterior motion of the mitral valve against the hypertrophied symptom. Most patients with hypertrophic cardiomyopathy have abnormal diastolic function, whether or not pressure gradient is present, which impair the ventricular feeling and increase feeling pressure despite a normal or a small ventricular cavity. The three explanations for the systolic anterior motion of the mitral valve in hypertrophic cardiomyopathy that cause obstruction have been offered as follows. The mitral valve is pulled against septum by contraction of the papillary muscle, which occur because of the valve's abnormal location and septal hypertrophy, altering the orientation of the papillary muscle. The second, the mitral valve is pushed against the septum because of its abnormal position in the outflow tract. The third one, the mitral valve is drawn toward the septum because of the lower pressure that occurs as the blood is ejected at the high velocity through the narrowing of outflow tract. Symptom of hypertrophic cardiomyopathy. Sign and symptom of hypertrophic cardiomyopathy might include one or more of the following: chest pain, especially during exercise; fainting, especially during or just after the exercise or exertion; heart murmur, which healthcare provider might detect while they listen to the heart; sensation, fast, fluttering, and palpitation; short of breath, especially during the exercise. Etiology for hypertrophic cardiomyopathy: abnormal calcium kinetic. Data linked abnormal myocardial calcium kinetics to the cause of inappropriate myocardial hypertrophy and specific feature of hypertrophic cardiomyopathy, particularly in the patient with diastolic function abnormality. Abnormal myocardial calcium kinetics and abnormal calcium flux from the increase in the number of the calcium channel result in an increase in intracellular concentration, which in turn may produce hypertrophy and cellular dysarthria. Genetic cause: familial hypertrophic cardiomyopathy occur as autosomal dominant in approximately 50% of the cases. Some, if not all, sporadic forms of the disease may be caused by spontaneous mutation. Abnormal sympathetic stimulation, heightened responsiveness of the heart to the excessive production of catecholamine or the reduced neuronal uptake of norepinephrine might cause hypertrophic. Abnormally thickened intramural coronary artery, this do not dilated normally, which lead to myocardial ischemia. This progress to myocardial fibrosis and abnormal compensatory hypertrophy. Subendocardial ischemia, this is related to abnormalities of the cardiac microcirculation that deplete the energy stored essentially for the sequestration of the calcium during diastole. Subendocardial ischemia result in persistent interaction of the contractile element during diastole and increased diastolic stiffness. Cardiac structural abnormalities, this includes curve configuration of septum, which result in myocardial cell hypertrophy and dysarthria. Risk factor for hypertrophic cardiomyopathy is usually passed down through the familial inheritance. People with one parent with hypertrophic cardiomyopathy have 50% chance of having genetic mutation for the disease. Parent, children, or sibling of the person with hypertrophic cardiomyopathy should ask their healthcare provider about screening for the disease. Complication: atrial fibrillation, thickening of heart muscle and change in the structure of the heart cell can cause change in the heart electrical system, resulting in the fast or irregular heartbeat. Atrial fibrillation can also increase the risk of developing a blood clot, which can lead to stroke. Blockage blood flow in many people, thickened heart muscle block the blood flow, leaving the heart, causing shortness of breath with exertion, chest pain, dizziness, and fainting. Mitral valve disease: if the thickened heart muscle block the blood flow, leaving the heart, the valve between the left atrium and left ventricle, mitral valve, might not close properly, as resulting blood can leak backward to the left atrium. Mitral regurgitation, possible, making symptoms worse. Dilated cardiomyopathy: in small number of the people with hypertrophic cardiomyopathy, the thickened heart muscle became weak and ineffective. The ventricle became enlarged, dilated, and it pumped less forcefully. Heart failure: the thickened heart muscle can eventually become too stiff to fill the heart with the blood. As a resulting, the heart cannot pump enough blood to meet the body needed. Fainting, syncope. An irregular heartbeat or blockage of the blood flow can sometimes causing fainting. Unexplained fainting can be related to sudden cardiac death, especially if it has happened recently and in young person. Sudden cardiac death, rarely hypertrophic cardiomyopathy, can cause heart related sudden cardiac death in people with all age, because many people with hypertrophic cardiomyopathy does not realize that they have it. Sudden cardiac death might be the first sign of condition. It can be happen in any healthy young patient, in any healthy young people, including high school athlete and other young active adults. Diagnosed hypertrophic cardiomyopathy. Physically, jugular venous pulse, prominent A-wave, or double carotid arterial pulse decline in the mid-systole as gradient develop, or double apical impulse force at left atrial contraction against non-compliant ventricle, or triple apical impulse lift at the late systolic bulge near isometric contraction. This one is normal. S3 gallop decompensate left ventricle, or S4 atrial systolic against hypertrophic ventricle. Whole systolic murmur, retrograde ejection flow, blood flow into the low pressure in the left atrium. This here at apex and axilla. Patient with the systolic anterior motion and significant left ventricle outflow gradient. Diastolic decrescendo murmur of aortic regate 10%, most likely in the systolic anterior motion. Diagnosis of hypertrophic cardiomyopathy. Echocardiography. Echocardiogram is commonly used to diagnose hypertrophic cardiomyopathy. This test is used to see if the heart muscle is unusually thick. It is also show how well the heart chamber and valve are pump blood. ECG show irregular heart rhythm and sign of the heart thickening. Cardiac MRI, this test used to provide information about the heart muscle and how the heart and heart valve working. Stress test is help to assess how heart respond to the physical activity. Coronary angiography, this test of the image show the coronary artery blood vessel to see if there is a block or not. Genetic testing, blood tests evaluated gene involving the heart in the hypertrophic cardiomyopathy. Genetic specialists can be helped to determine whether you or your family member should get genetic test. This is a cardiac MRI for hypertrophic cardiomyopathy. Differential diagnosis: aortic stenosis, genetic disease, hypertensive heart disease, pediatric supravalvular aortic stenosis, restrictive cardiomyopathy, type 2 collagen storage disease. This is the difference between athlete and hypertrophic cardiomyopathy. And we see here the left ventricle cavity for the hypertrophic cardiomyopathy is less than 45, while in the athlete more than 45. And we see the LV cavity for the athlete more than 55. And abnormal left ventricle feeling, see it in the hypertrophic cardiomyopathy, familial gender, more with the hypertrophic cardiomyopathy. Family history should be more with the hypertrophic cardiomyopathy. Treatment. The goal of hypertrophic cardiomyopathy treatment are to relieve the symptom and prevent sudden cardiac death in people at high risk. Treatment depends on the severity and symptom. Of the symptom. Medication can help reduce how strongly the heart muscle squeeze and slow the heart rate, so that the heart rate can pump blood better. Medication to treat hypertrophic cardiomyopathy and its symptom including beta blocker, as example metoprolol, propranolol, and atenolol, calcium channel blocker, tropamidine, heart rhythm control, we need it as amiodarone and disopiramide. Blood thinner like warfarin, rivaroxaban, apixaban, to prevent the blood clot if you have a relation or apical type hypertrophic cardiomyopathy, which can increase the risk of sudden cardiac death. Surgery. The type of surgery for hypertrophic cardiomyopathy, first the one septal myomectomy. The open heart surgery might be recommended if the medication do not improve the symptom. It involves remove a part of the thickened, overgrowing wall symptom between the heart chamber. Septal myomectomy have helped improving the blood flow out of the heart and reduce the background flow of the blood through the mitral valve, mitral regurgitation. The surgery can be done using different approach depending on the location of the thickened of the heart muscle. It in one type called apical myomectomy. Surgery remove the thickened heart muscle from the near the tip of the heart. Sometimes mitral valve is repaired at the same time. The other procedure is septal ablation. This procedure destroys the thick end of the heart muscle with alcohol. Alcohol is injected through along a thin tube catheter into the artery, supplying the blood to that area. Possible complications including disruption of the heart electrical system, heart block, which requires implantation of the pacemaker. The other procedure is implanting ICD. ICD is a small device that continuously monitoring the heartbeat. It's implanted in the chest like a pacemaker. If the life-threatening arrhythmia occurs, the ICD delivery precisely calibrated electrical shock to restore the heart rhythm. Using of an ICD has been shown to help prevent sudden cardiac death, which occur in small number of the people with hypertrophic cardiomyopathy. Here we see the comparing between ICD, septal myectomy, and septal ablation. The best one is septal myectomy, mortality less than 2 to 3%, residual gradient less than 10, effectiveness more than 20%, 90%. This follow-up for 30 years. Complication for the surgery, complete heart block less than 3% of the patient, ventricular septal defect less than 1, aortic regurgitation less than 1. The time of resolution of the gradient immediate. The second one is septal ablation, mortality less than 2 to 3%, residual gradient less than 20, effectiveness 70 to 80% of the patient. Follow up this for 5 years, less than 5 years. Complication, complete heart block, it happened between 10 to 40% of the patient, ventricular septal defect and large myocardial infarction. Time of resolution of the gradient for septal ablation is between 8 to 12 weeks. The third one is dual chamber. Mortality less than 1%, residual gradient less than 40, effectiveness between 10 to 40% of patient. This follow-up 14 years. Complication for this procedure for ICD, infection or perforation. It happened less than for the patient less than 2%. Resolution of the gradient 4 weeks. The last procedure is the last surgery for the patient is heart transplant. Is recommended in the specific situation for a patient with hypertrophic cardiomyopathy. The indication for the heart transplant, including advanced heart disease and New York Heart Association functional classes 3 or 4 symptoms that are refractory to all other intervention. In addition, transplant referral for refractory symptom does not require a reduced ejection fraction, and heart transplant is performed in the presence of preserved ejection fraction. And hypertrophic cardiomyopathy patient outcome after heart transplant is not different from that other patient with other heart disease. I see here the diagram for the hypertrophic cardiomyopathy. The patient have sudden high risk for sudden cardiac death. We put ICD, we refer ICD. If the patient have the genetic or the family or sibling have hypertrophic cardiomyopathy, we prefer to refer the patient for genetical assessment. If the patient have a heart failure symptom with the AFib, atrial fibrillation, we prefer to give the patient anticoagulant or ICD, ICD and pharmacological affecting the heart rate. If not, if there is no benefit, we prefer to do ablation or the nasal procedure. If the patient have no or mild symptom, if there is no symptom, we're not prefer to give the drug. If the patient have mild symptom, we prefer to give the patient calcium channel blocker or beta blocker or heart rhythm control, disopyramide. If the patient have the refractory symptom, it will be 2 types, obstructive or non-obstructive. For obstructive patient, we prefer to do surgical septal myectomy, and there is alternative surgery like alcohol septal as we talked before, and ICD dual chamber. If the patient non-obstructive cardiomyopathy, we treat the patient as a heart failure medication like a decrease after load with diuretic, digoxin, beta blocker, and spironolactone. If there is not benefit, we prefer the patient to do the patient heart transplant. Activity for hard hypertrophic cardiomyopathy patient. Avoid strenuous exercise. Competitive level sport should not be permitted if any of the following is present, like significant outflow gradient. We not prefer if the patient have like this. Significant ventricular or supraventricular arrhythmia. We not prefer to do strenuous exercise. If there is marked LV hypertrophy, history of sudden death, a relative with hypertrophic cardiomyopathy, so we not prefer. Young age, less than 30, we not prefer to do strenuous exercise. Abnormal blood pressure response to exercise, history of syncope, particularly in the children. So this is all, and thank you very much for listening.
Thank you, Mohammed. Thank you. Have you any question or comments for okay. The next talk will be by Dr. Ahmed Al-Amri, arrhythmia surgery at 3 p.m. inshallah.
السلام عليكم جميعا.
السلام ورحمة الله وبركاته.
وعليكم السلام ورحمة الله.
Okay, I'm actually being honored to be invited as a speaker or supervisor for this session, and I'm looking forward for a useful discussion, inshallah. I think we can start.
Sure. Thank you, Dr. Mohammed, for accepting our invitation. My name is Ahmed Amri. In Salman Heart Center, King Fahd Medical City. I will be presenting today surgical treatment for atrial fibrillation.
Ahmed, you hear me? Make sure your internet connection is good because your voice is cutting and we didn't start yet. So I don't know. Make sure your connection is okay before you start, please.
Okay. You can hear me now? Can you hear me now?
We can hear you, but it's interrupting. We cannot understand the things.
Let's start again.
Yes. You can hear me now clearly?
Yeah, it sounds good now.
Because I'm in the hospital. Yeah, okay. My objectives for this presentation is to give an introduction and to define surgical ablation to give some surgical ablation. As an introduction, atrial fibrillation is the most common adult arrhythmia worldwide, and it's associated with increased risk of mortality, and it has 5-fold increased risk of stroke, and it is associated with, as well as the macro re-entry phenomena in dilated area in the atrial tissue.
Dr. Ahmed, sorry for interruption, but I think the connection issue is still there. It's not fixed.
Okay, I will try to from another. Just give me 5 seconds. Can you hear me now clearly?
Yes, now it's better.
Thank you. So the pathogenesis of atrial fibrillation is associated with electrical triggers in the pulmonary veins, as well as the macro re-entry phenomena that is in dilated area in the atrial tissue. There is several established options for the treatment of atrial fibrillation, but with suboptimal result until now. So atrial fibrillation generally classified into 4 categories. First is paroxysmal atrial fibrillation, which is spontaneous termination within 7 days persistent atrial fibrillation when it's more than 7 days, but less than a year. Long-standing persistent atrial fibrillation when it continue more than a year. Permanent atrial fibrillation, it's a term that is agreed on between the physician and the patient when there is agreement on no further rhythm control treatment is needed. So the history of Maze procedure. In 1980, Dr. James Cox first introduced surgical ablation as treatment for atrial fibrillation, and it was called Maze 1 operation. Through ongoing investigation and optimization of the procedure, it evolved into Maze 3 and became the gold standard surgical treatment for atrial fibrillation. However, Maze 3 was a procedure that was performed by a cut and sew technique, and because of presence of alternative energy sources, and nowadays and its effectiveness in replacing the cut and sew technique, the Maze 4 procedure coined to be to describe the Maze 3 with using alternative energy sources like radio frequency or cryothermic energy. So this picture shows the evolution of Maze procedure. Maze 1 procedure, as you can see, and with better understanding of the pathophysiology of atrial fibrillation, new lesions have been described, and through Maze 1 and Maze 2, Maze 3 was performed through cut and sew technique, and the Maze 4 replacing the cut and sew with the energy source. So to better understand how does Maze procedure restore the sinus rhythm in patient with atrial fibrillation, we have this diagram in the left side showing the macro re-entry circuits in the red circles, and this is the main pathophysiology behind atrial fibrillation, the presence of those macro re-entry circuits. And by doing the Maze lesions, we are creating these lesions to break those macro re-entry circuits and preventing atrial fibrillation from happening. So by this, restoring the sinus rhythm in those those type of patients. So the Cox Maze 3 procedure, the cut and sew procedure, was, as you can see, performed by cutting into the atrial tissue and sewing. As you can imagine how difficult it was and how complication can happen post the cut and sew technique from bleeding and so on. That's why the Cox Maze 4 was evolved into using alternative energy sources. Example for those energy sources used in the Maze procedure: unipolar radio frequency, bipolar radio frequency, laser, microwaves, and high intensity focused ultrasound, and cryotherapy as well. The radio frequency ablation, either by unipolar or bipolar. The unipolar radio frequency can be applied as an endo or epicardiac approach, and it can heat the atrial tissue up to 90 degrees Celsius. The bipolar radio frequency delivers the energy in between the clamp of the jaw of the radio frequency clamp, and it can heat the atrial tissue up to 60 to 70 degrees Celsius. The main limitation behind the radio frequency is the risk of injury to the coronary arteries and the valve tissues due to hyperthermia denaturation of the collagen. That's why cryothermia was used for the type of lesions close to the coronary arteries and the valve tissue. So the cryothermia ablation is producing injury to the tissue by forming intracellular, cellular, and extracellular ice crystals. It used two different type of gases, either nitrous, which can freeze the tissue up to -89 degrees Celsius, or argon, which can freeze the tissue up to -187 degrees Celsius. Now, for the Cox-Maze 4 operation, it, as I mentioned, it's using the either radio frequency or cryoablation mainly. There is two different type of lesion set, the right atrial lesion set and the left atrial lesion set. The right atrial lesion set consists of performing right atriotomy, and by doing right atriotomy, you created the first lesion, and connecting the right atriotomy to the SVC. This is a second lesion, and then you will do the IVC lesion, then performing the right atrial free wall lesions, and connecting that lesion to the tricuspid annulus, and performing the atriotomy edge to the tricuspid valve annulus lesion, and by this you complete the right atrial lesion set. Then we have the left atrial lesion set, by performing then again left atriotomy, you create the first lesion, and doing the box lesion, which consists of isolation of the pulmonary veins, the superior and inferior pulmonary veins, connecting those lesions together, completing the box lesion, and doing your lesion toward the mitral valve annulus, and the lesion toward the left atrial appendage, and by the end, Cox-Maze 4 will not complete without doing left atrial appendage closure. So again, this diagram shows you the different lesion set that we performed for the Cox-Maze 4 using alternative energy sources, cryoablation, bipolar radiofrequency, or the surgical incision that we performed. I have a video I want to share. You can see the video.
Yeah, just play it so we.
You can hear.
No.
You cannot hear the audio.
Yeah, I cannot hear anything.
Okay, I'll try to describe. So in this video, they share a case of aortic valve replacement with mitral valve repair in concomitant with my Maze procedure, Cox-Maze 4 procedure. So let me play it just to the parts of Maze procedure. So they performed the procedure robotically. They started with the aortic valve. They opened the right atrium, as you can see. The left atrium, sorry, and they started with marking the lesions first. This lesion toward from the atriotomy to the mitral valve annulus, and they're doing now the isolation for the pulmonary veins. This is by using cryoablation. Right iterotomy done, and they are doing the SVC lesion. Right atrial appendage line. Closing the left atrial appendage, as you can see. And they then moved on to the mitral valve repair. So if you go to the guidelines of surgical ablation,
Ahmed,
yes,
thank you so much. Go back, please, to the diagram you showed when you showed us the line in the red and
yes,
yeah, this line, yes. So you have to appreciate this diagram, which came from a study which you use a bipolar radio frequency ablation, and they continue with and they have to use a cryoablation to be able to continue the lesion sets. But the video you showed, it's actually basically you can do the same operation without using the bipolar. You can do the full maze procedure using a cryoablation. That's what we are doing here now in King Fahd Medical City. So to give you the difference between the two procedures, if you're going to use the bipolar, first of all, you have to go around both pulmonary veins, as we do the BVI, the pulmonary venous isolation, and then you have to use the clamp around these pulmonary veins. Then you will open the left atrium as you did, and then you will use the clamp again to connect the two pulmonary vein isolation. And then you have to cut the left atrial appendage, and you have to use the clamp from left atrial appendage toward the left superior pulmonary vein. And the final lesion, you will use also the clamp from the atriotomy toward the mitral valve annulus at the area of B3. Then then you have to use the cryoablation from outside of the heart and inside of the heart to make sure that you cover the mitral, the coronary sinus lesion. This is in the left. On the right, you do your here in the right. It's a little bit different. You don't need to do you do the atriotomy as you show, and this atriotomy usually not transverse, is actually horizontal and more toward IVC. And then you use the bipolar clamp to go to SVC and IVC, as you can see here in this diagram. And then you use the clamp from atrium to the tricuspid annulus, and then you have to make a small hole in the left atrial appendage, and you have to come close to the mitral tricuspid annulus and then to the free atrial wall. And then you have to use again the cryoablation to be able to finish up what you started with the probe, with the cryo probe. So as you can see here, you can do both operation and both energy resources, but you can do this simply by using only one energy resources, which is the cryo. And how we do that in the operating room? First of all, you start your operation like usually when you do this, it's usually combined with either mitral or any other valve lesion. Most likely it's combined with mitral. So you set your case as you're doing mitral. You do ascending aortic cannulation by cable cannulation. Then you develop your SunGuard groove, so you'll be able to open the left because when you do a Cox Maze 4, you cannot go transeptal. If you go transeptal, you carry a very high risk of having the patient will have a heart block and pacemaker. You have to do a biatrial approach. So you develop SunGuard groove, you open the left atrium as you see, as we do usually in any cases like mitral, just like doing a mitral. But you have to make sure when you do that, you have to see the coronary sinus and its relation to the mitral valve. So you will be able to do a perfect ablation. After you open the left atrium, you put an LV vent on the left atrium just to make sure there is no blood, because if there is blood in the field, sometimes it can affect your line of ablation. The first lesion you do on the left, you start with the left coronary sinus. You go from outside of the heart toward the mitral valve annulus B3 area, and you have to be careful. Sometimes your probe can go a little bit medial and then go from B3 to B2, and sometimes the patient can get a circumflex injury. So you have to make sure you only point it toward B3. You usually use a cryoablation for 3 minutes. After that, you stop. Then you start doing the BV isolation. BV isolation, or what you call box lesion, from inside of the heart. This you go from the lower edge of the left atriotomy to the left atrial appendage. So you excluded almost all the back wall of the left atrium. And this also will take in consideration the area of the left superior pulmonary vein. You guys can hear me?
Yes, yes.
Then you continue the back wall isolation by doing the J lesion, which goes from the upper edge of the sternum downward toward below the level of the left atrial appendage. After that, by this you almost complete 90% of the left atrium. You have to do what you call the mitral annulus lesion, and this is corresponding to the same area where you did your coronary sinus. When you do your coronary sinus and you see the freezing on the left atrium, you have to mark it, because you have to ablate on that line again, because you want to prevent a very important phenomenon called atypical left atrial flutter, and this is very intolerable for patients. You finish the left atrium, you drop it, you go to the right atrium. When you go to the right atrium, you're going to do ablation with cryo. You have to be careful. You have to give blegia. And this is what you can see in my operating room all the time. When you do this operation, you start with the blegia, because you want to make sure that when you do the tricuspid valve annulus, you do not affect the right coronary. You do your right atriotomy, transverse incision, longitudinal incision, and then this more toward IVC. And after that, you ask your assistant to hold the two edges so you can see the tricuspid. So at that area, you will see the tricuspid, and you will see the junction between the posterior and anterior tricuspid valve, and this is what you call the tricuspid valve annulus. So you put the probe from the upper edge of the right atriotomy toward the tricuspid annulus, given blegia, because you want to make sure you do not affect the RCA. You freeze for a couple of minutes, you release. Then you do the SVC lesion, which is going from the lower edge of the atriotomy all the way to the SVC, lateral wall of the SVC. Here you have to look into two things. Number one, phrenic is always close to SVC. You have to make sure that the probe does not touch the phrenic. Two is the SA node. You have to be very low at the IVC, at the SVC, so you don't come close to the SA node and cause SA node dysfunction. Then you do the right atrial wall, free atrial wall. You go from the upper part of the right atriotomy to the left atrial appendage. And finally, you do the IVC, which is the same correlation to the SVC. You go from the lower part all the way to the lateral wall of the IVC, and also you have to watch for phrenic. By this, you finish all the lesion using cryo. After that, you drop the right, you stop the bleach, and then you go to the left side, and then you start closing the left atrial appendage, and then you continue the operation as doing any other operation. Usually, this procedure will take up to 30 minutes. You need 20 minutes resting time, or like clamp time without bleach on the left side, and about 10 minutes to do the right side. But we do the right side while we're giving bleach. So I don't consider this as an ischemic time. I just want to give you what the difference between both procedure and how we do that efficiently. Shukran.
Thank you, Dr. Mohammed. So now we'll move to the guidelines. The first guidelines I will speak about is the HRS consensus of expert consensus published in 2017. They classified the indication for surgical ablation into 3 categories. The first category is in concomitant with open procedure like mitral valve. In this category, in patients with symptomatic atrial fibrillation, either paroxysmal or persistent or long-standing persistent atrial fibrillation, it's class 1 to go for surgical ablation in concomitant with the other open procedure. For the concomitant closed procedure like CABG or AVR, in symptomatic AFib patient with paroxysmal or persistent or long-standing AFib, it is class 2A to go for surgical ablation directly. It's class 1 to go for surgical ablation after failing antiarrhythmic medication. For the standalone surgical ablation in symptomatic patient with atrial fibrillation, in paroxysmal AFib, you should go for first with antiarrhythmic drugs. If failed, it's class 2B to go for surgical ablation. In persistent atrial fibrillation, after failing antiarrhythmic drugs, it's class 2A to proceed with surgical ablation. And again, in long-standing persistent AFib, after failing antiarrhythmic drugs, class 2A for surgical ablation. For the STS guidelines in 2017 for surgical treatment of AFib, in patient with mitral valve operation, so if you are if you have a patient with mitral valve and with atrial fibrillation, surgical ablation can be performed without additional risk of operative mortality or major morbidities, and it's recommended at the time of doing the mitral valve as a class 1 level of evidence A. In case of aortic valve or CABG operation, surgical ablation can be performed without additional risk of mortality morbidities, and is recommended at the time of doing the aortic valve or the CABG, or both CABG and AVR, as a class 1 level of evidence B, non-randomized. Standalone surgical ablation in symptomatic patient in the absence of structural heart disease that's refractory to class 1 and 3 antiarrhythmic medication or catheter-based therapy, it's reasonable to go for standalone Maze procedure or surgical ablation in general to restore the sinus rhythm as a class 2A level of evidence B randomized. Also, in patients who have symptomatic persistent or long-standing persistent AFib in the absence of structural heart disease, it's reasonable to do standalone procedure using the Cox-Maze 4 or 3 lesion set compared to the BVI alone. It's class 2A level of evidence B. Another meta-analysis was published by the AATS consensus of expert consensus guidelines, and they found that this meta-analysis resulted with that surgical ablation did not increase the post-operative morbidities, and surgical ablation again showed improvement of quality of life, and it showed improvement in the long-term survival. It did not increase the length of hospital stay or ICU stay or hospital readmission. There was no difference with surgical ablation in regard of risk of developing TIA or stroke. For the outcome for surgical ablation, there are multiple studies examining the outcome for surgical ablation, starting with this study in the long-term outcome following concomitant mitral valve surgery with Cox-Maze procedure, published by Dr. Nave Ad and his group, and they assessed a good number of patients, around 400 patients, over a long period of time, over 84 months, and they found the percentage of patients in sinus rhythm with antiarrhythmic medication at the first year around 90%, and of antiarrhythmic medication, around 83%. And throughout the follow-up period, there was a significant drop in number of patients followed up. That's why maybe there is a drop in the patient with the sinus rhythm over the long period of time follow-up. It's reaching 66% sinus rhythm over 84 months follow-up. This is their also they published their freedom from embolic stroke, which was significantly high percentage, which is 96.6% over 84 months had freedom from embolic stroke, which is the main burden behind atrial fibrillation. This is another study by Dr. Vinay Padwar and his group, 1 year mortality and costs associated with surgical ablation for atrial fibrillation and concomitant with CABG. And they studied they compared patients who underwent CABG alone versus patients who underwent CABG and ablation in patients who required CABG and had an atrial fibrillation. So over the period of follow-up, which reached 360 days, they found the probability of death for the patient who underwent CABG plus a surgical ablation was significantly lower than the group who underwent only CABG and left up with untreated atrial fibrillation. The next study is long-term safety and efficacy of concomitant Cox-Maze procedure for atrial fibrillation in patients without mitral valve disease. That was believed in the past that the best outcome for Cox-Maze procedure was only associated with mitral valve disease. But in this study by Dr. Nevad and his group, they assessed patients and compared patients who had Maze procedure with mitral valve and non-mitral valve over 5 years follow-up. And they found that the percentage of patients who were in sinus rhythm post-operatively, which is represented in the red bar, was higher than the group with mitral valve, but it was close to them, like 91% in the non-mitral valve group and 88% in the mitral valve group over 1 year follow-up, and reaching up to 72 and 80% at 5 years follow-up. So by this, they found that a patient who will undergo Maze procedure with mitral valve and without mitral valve have a similar outcome. And this is their study population, around 470 patients with mitral valve and 238 patients with non-mitral valve surgery. They followed them up to 10 years. and result was similar operative result in terms of stroke, reoperation for bleeding, renal failure, pacemaker requirement, operative mortality, readmission at less than 30 days, and also in the length of hospital stay. And the outcome was similar in the 5 years in terms of freedom from stroke. And they have found that the predictor of success for the Maze procedure was the less the duration of atrial fibrillation preoperatively, and the more the surgeon experience in the surgical ablation was associated with better outcome. So here they examined the late outcome after Cox-Maze 4 for atrial fibrillation. This is study by Dr. Ralph Domeno and his group. They assessed the difference between paroxysmal and non-paroxysmal AFib in restoring the sinus rhythm post-operatively, post-surgical ablation. And in both group, they had almost similar percentage of sinus rhythm post-operatively, especially over the 5 years of follow-up. Another study by Dr. Ralph Domeno and his group, performance of COX-MACE4 associated with improved long-term survival in patients with atrial fibrillation undergoing cardiac surgery. And this study is important to illustrate the long-term outcome of atrial fibrillation because you can see the first diagram, the overall survival of patients who underwent COX-MACE4 in comparison to those who have untreated AFib is significantly better with the COX-MACE4 than the untreated AFib. And in the other diagram, it shows you how comparable the outcome in terms of survival between the patient who underwent COX-MACE4 and the one with no AFib even preoperatively. So restoring the sinus rhythm with COX-MACE4 give you a result of patients with no atrial fibrillation even preoperatively. In KFMC, we have also our own experience. We presented it in last Saudi Heart Association meeting last year. We performed around 26 cases of COX-MACE procedure in concomitant with cardiac surgery, and we published our early results. So we, as I mentioned, 26 cryo-MACE procedure, and we analyzed those patients in terms of hospital mortality, 30 days mortality, and 30 days freedom from atrial fibrillation. Our result was that no in-hospital or 30 days stroke had occurred. The mean hospital stay was around 7 days, survival at 30 days around 96%, and the overall freedom of atrial fibrillation at 1 month follow-up was 87%, 87.5%, which was comparable to the literature, as you can see. Lastly, left atrial appendage management. By this study in the New England Journal of Medicine, which was published recently, where they did the randomized control trial comparing closing the left atrium during cardiac surgery versus not closing the left atrium in AFib patient. There was around 4,811 patients who were diagnosed with atrial fibrillation with a CHA2DS2-VASc score more than or equal to 2, undergoing other cardiac surgery. And there was significant decrease in risk of ischemic stroke on non-cerebral systemic embolization over the follow-up period, significantly better in terms of stroke with the patient who underwent left atrial appendage occlusion. So left atrial appendage occlusion during cardiac surgery reduced the risk of ischemic stroke and systemic embolization in patients with history of atrial fibrillation. How do we close the left atrial appendage? There are 3 main ways, which is internal ligation or stapling the left atrial appendage, or surgical excision or amputation. There was no many studies studying the difference between those techniques, but I found this randomized prospective study comparing the 2 atrial appendage elimination technique in small number of patients, but they found that interoperative evaluation of the left atrial appendage elimination techniques, the residual stump in the group of internal ligation was 0, and the stable excision around 1 patient and 2 patients in the surgical excision group. Over the late evaluation of these 3 techniques, the residual stump was the lowest with the internal ligation group. So mainly internal ligation is the safest option for closing the left atrial appendage in terms of not leaving a residual stump. So as a take-home message, surgical ablation had the best result in restoring sinus rhythm in comparison to other modality of the treatment of atrial fibrillation. Surgical ablation by Cox-Maze-4 is safe, and studies showed better survival and better quality of life. Surgical ablation is recommended as a class 1 in concomitant with mitral surgery, KPGR, or AVR. And left atrial appendage occlusion is part of Cox-Maze-4. If Maze was not done, left atrial appendage should be closed during cardiac surgery in AFib patient. Arrhythmia surgery needs experience and special training. Thank you. And if you have any comment, Dr. Mohammed.
Shukran, Ahmed. Let's hear from the guys, and then I will comment. If anybody have questions or comments from your colleagues. Seems there is no comments, huh? You hear me?
Yes. Any comment,
so-
guys? Any question for Dr. Mohammed?
Okay, I want to give a brief just summarization of what you have said and for the guidelines. Before the guidelines came from the Heart Rhythm Association and from the STS, if you look at the AHA guidelines, the arrhythmia surgery was always never been class 1. It's always like class 2A or 2B. But after the body of evidence that supported that you doing ablation, it's actually improve survival, improve patient quality of life, decrease the use of antiarrhythmic medication, decrease the use of anticoagulation. So the expert they actually met and they start to revise this guidelines, and they came up with what you have said. Now it's easy when you have a patient who comes to the operating room because he has another pathology such as mitral, CABG, or aortic valve. It's easy to support that you will go for a concomitant Maze. But always the dilemma and the question comes when you have a standalone Maze. In my opinion, standalone Maze is as important as if you're going for a concomitant ablation with other cardiac surgery, especially if the patient is already in maximum therapy of antiarrhythmic medication. Also, he already underwent surgical or not surgical transcatheter ablation, and he's still symptomatic. So if you have these kind of patients who comes to your clinic complaining from atrial fibrillation, I think they deserve to be treated from long Maze. You can do long Maze from different approach. You can do it from doing any conventional cardiac surgery with median sternotomy, or you can do it from right thoracotomy with as you do minimally invasive mitral surgery. Now, you also have to be careful when you read the literature and the data when it comes across the atrial fibrillation. First of all, when you read the paper talking about outcome atrial fibrillation, you need to know what kind of atrial fibrillation they're talking about. Are they talking about paroxysmal atrial fibrillation, persistence, long-standing persistence, permanent? Because it's very important, because type of atrial fibrillation also affect your outcome. This is number one. Number two, what are the pathology related to the atrial fibrillation? Is it how many patients they have mitral valve disease? How many patients they have tricuspid valve disease? How many patients they have other coronary artery or aortic? And how many patients they come for solo Maze? Why I'm saying this? Because our population that we serve here in Saudi Arabia is totally different. I was trained with Vinny Badouar, and I did a lot of Maze operation on the States. The outcome there is better than the outcome of Saudi Arabia because the patients there are different. Most of the patient there, they come with a degenerative mitral valve with reasonable left atrial size and without left atrial thickening. But in our population here, if you can see, the number one pathology that we treat is mitral valve stenosis. And these patients, or the rheumatic heart disease, those patients, they come with very bad dilated left atrium, very thickened. Even though with this pathology, we got an outcome that's very close to the, or even like sometimes better, some of the series on literature, which is 87.5%. And this is only, they show the data for the end of the last year. We did not include everybody. Did we include everybody, Ahmed, in the study? No, not yet, right?
Not yet, no.
We did more patients, you know. So as you can see, with more patients you do, I think the outcome will even be better. I think we'll touch more than 90%. And to be honest with you, with the cohort of the patient that we're treating, I think it's actually comparable with what we see in on literature. So always it's important for you as a new trained surgeon. I think having the tool of surgical ablation is very important, because you will be able to restore a normal sinus rhythm in a patient. And the advantage of restoring a normal sinus rhythm, actually three. One, you improve the patient symptoms. Even the heart failure symptoms improve. And to be honest with you, now there is a lot of literature in the literature supporting that if the patient comes with mitral or with concomitant cardiac surgery and atrial fibrillation, it's good to treat atrial fibrillation because their heart failure symptoms actually improve faster and better. Number two, if the patient is going for a concomitant other cardiac surgery that does not require anticoagulation, we don't anticoagulate MACE procedure. And the guys who works with me, when we do a MACE for mitral valve repair or tissue mitral valve, or like a MACE with aortic valve, tissue valve, we do not anticoagulate these people. Number three, you are actually not giving them, you give them antiarrhythmic medication only for 3 months, and after that, all of these patients should be in beta blocker. Number four, you're preventing stroke. As you can see here, the number of stroke after MACE procedure is like, we did a study in West Virginia. We actually had 2 strokes out of 100 patients, and 2 of them, they were actually hemorrhagic, not even embolic. And the most important thing, you have to follow your patients very closely and carefully. You ask the patient to come to the clinic in the first month, second month, third month, 6th month, up to 9 months, and all these follow-ups should be done with ECG. And even if the patient goes into atrial fibrillation in the first 3 months, we don't consider this as a failure, because you still have what you call the blanking period, when the patient have actually post-operative inflammation. So you still treat them with amiodarone and sometimes cardioversion, and after that they will convert back into normal sinus rhythm. However, you cannot claim success unless the patient passed 1 year after the surgery and he's in sinus rhythm. After 9 months, you have to do a Holter monitor, and from 9 months all the way to 5 years, you have to follow him up with Holter monitor. You follow him at 9 months, 1 year, 1 year and a half, 2 years, 3, 4, and 5, and then after that you can stop follow-up, because at that point, you know that this is the maximum duration you can follow the patient with to prove that he's out of his atrial fibrillation. I think, as Ahmed mentioned, surgical treatment of atrial fibrillation need training, and people has to be very comfortable, because a lot of people shy away because they think it might increase the clamp time, the pump time, complicate the operation. Yes, it might, but I think with the proper training and the proper selection of the patients, you can get the patient a very good outcome with very low mortalities and morbidities. So again, I'm very happy to be with you today, and actually it's very good to end your week with a nice lecture and nice presentation and a nice refreshment. And I'm very happy to get any questions or any comments from the group. شكرا لكم. Are we okay? Guys, no questions at all? You understand كل كلمة قالها أحمد ما شاء الله. This is amazing. Okay, then I guess we're done today, huh?
Thank you, Dr. Mohammed. Thank you very much for accepting our.
No, it's my pleasure. Okay, you guys have a good weekend. مع السلامة.